Dysnatremias are a major problem in modern critical care. About 30% of our patients have high sodiums or low sodiums. This particular tutorial is the first of a series on hyponatremia. I'm going to explain the problem, the underlying physiology, and how to work the problem. I guarantee you'll learn something. Hyponatremia, Part 1, Understanding the Problem. In this tutorial, I'm going to discuss what hyponatremia is, the different types of hyponatremia, and the diagnostic pathway for hyponatremia. Let's start with a clinical scenario. You're called to the emergency department to see Maureen, who is 56 years old and seizing. On her venous blood gas, her sodium is 120 millimoles per litre. While you're seeing Maureen, Matthew also rolls into the emergency room. Now, this man has a history of hypertension, congestive heart failure, but he's come in with mild flu-like symptoms. His Glasgow coma score is 15, and on his venous blood gas, his sodium is 120 millimoles per litre. So we have Maureen with a sodium of 120, and we have Matthew with a sodium of 120. And here's the thing. Maureen needs immediate treatment with hypertonic saline. Matthew needs none. All you need to do with him is do some blood tests and restrict fluid and figure out what's going on. So Maureen has presented with what we call symptomatic hyponatremia. Let's try and understand the problem. Sodium abnormalities should be considered as disorders of extracellular osmolality rather than disorders of sodium balance. So let's make sure we get our terminology correct. When we use the term osmolarity, that's with an OR, we're talking about the number of osmoles per unit volume, and that means per litre of fluid. These are the particles that we can actually see on our chemistry panel. Osmolality represents the number of osmoles per unit weight, and that is per kilogram of fluid. And as water changes its volume with temperature, but not its mass, osmolality as a term is more accurate. We use osmolarity when we're doing ward rounds and we do calculations of what we think the patient's plasma osmolality is. And it's calculated as in millimoles per litre, twice the sodium plus the potassium plus the urea plus the glucose. That number should come in at between 290 and 310 milliosmoles per litre. When we're talking about osmolality though, this is something that has to be measured in the lab. And one of the problems with this is that you have to wait for the lab to actually do the test for you. And it's a really important test, as we'll see when we're talking about hyponatremia. Osmolality is the same between the intracellular and extracellular space. And I'm going to give you an average number here of about 300 milliosmoles per kilogram. As 2/3 of body water is located in the intracellular space and 1/3 in the extracellular space, osmolality is distributed along the same lines. As there is approximately 15 litres of extracellular fluid and 300 milliosmoles per litre, or per kilogram correctly, that results in 4,500 milliosmoles in the extracellular space and about 9,000 milliosmoles in the intracellular space. The total active extracellular sodium is only 15% of the total. That is 2,100 milliosmoles. But because sodium concentration is so tightly controlled by the body and it can be easily measured, it has traditionally been used to infer and calculate total body osmolality. Nevertheless, remember, sodium is just one of several osmotically active particles, and they're all important. And in some ways, sodium has been given outsized importance just because it's the most abundant particle. Why we are able to calculate out osmolarity based on just the sodium and the potassium is because of electrical neutrality. All the cations must equal all the anions. The major cations are sodium and potassium. Calcium and magnesium make little osmotic contribution. The total negative charge is chloride, bicarbonate, phosphorus, and a whole bunch of unmeasured anions, but all of them together must equal the same charge as the cations. Albumin particles are colossally large and have minimal impact on osmolality. So if you know the sodium and the potassium, you are able to calculate out all the dissociated charges. All you need then is the glucose and the urea in millimoles per litre, which is the same as milliosmoles per litre. Now that you have all these data, you can calculate out osmolarity. There are two formulas for this. The first one on the top is the one that I use because I live in the world of millimoles per litre. So it's very simple. It's twice the sodium plus the potassium plus the glucose plus the urea in millimoles per litre, and that will give you a result. If you live, for example, in North America, you may use milligrams per deciliter. So you need to convert the glucose from milligrams per deciliter into millimoles per litre. So that's the glucose divided by 18. But you'll also need to convert the urea from blood urea nitrogen to urea, which is the BUN divided by 2.8. But these two formulae give you exactly the same results once they've been converted together. To understand why you might treat these two patients differently, remember Maureen with a sodium of 120 versus Matthew with a sodium of 120, we need to look at the impact of osmosis on the brain. Water is freely permeable across cell membranes. It is constrained by the solute concentration on either side of the membrane. In this case, the solute concentration is constant, so there is no movement of water. In these examples, the brain is on the left-hand side of the screen and the membrane is the blood-brain barrier. Importantly, water moves across the solute concentration gradient. It goes from where the solute is in high concentration to where it's in low concentration. The key part of the body that we're interested in with regard to sodium is the brain. The blood-brain barrier is fully permeable to water, but it's relatively impermeable to charged particles, particularly electrolytes such as sodium chloride and potassium. Hence, the brain is vulnerable to osmotic shifts. What do I mean by this? Maureen has become acutely hyponatremic, so in this case there are more particles on the left side of the screen, and that is the brain side of the membrane. As the osmotic forces are greater there, water will consequently move along the concentration gradient from the blood into the brain, and that is the process of osmosis. This continues until the concentrations are equal, but importantly, as the water content is now greater on the left side, the volume of tissue has increased also. In other words, the volume of brain tissue has increased. Let me illustrate why this is important. This is a picture of a brain. I'm also drawing a single blood vessel leading into it, representing the carotid arteries and the vertebral arteries, but there's a huge vascular system in the brain. And if you look at the blood osmolality, it's approximately 295 milliosmoles per kilogram with a plasma sodium of 140 millimoles per litre. If you were to measure the brain osmolality, it would be exactly the same, 295. Now let's have a look at another patient, Rachel. Rachel consumes several litres of water, and for some reason she's not able to expel that water from her body. Consequently, her blood osmolality falls to 240 milliosmoles per kilo with an associated drop in the plasma sodium to 118 millimoles per litre. By contrast, her brain osmolality is completely normal, 295 milliosmoles per kilo. The result of this is that water rapidly enters the brain along the osmotic gradient. That will continue until the brain osmolality reaches about 240 milliosmoles per kilo. And as a consequence, the brain will become really swollen with water and there is diffuse cerebral edema. Symptomatically, Rachel will initially have some isolated neurological findings, but this may result later in seizures. If she doesn't recover from that, coma will follow, possibly brainstem herniation, and ultimately death. Because Rachel has symptomatic hyponatremia for example, Rachel may present with seizures, we're going to go ahead and give her hypertonic saline solution. This is 100 mils of 3% saline. And the idea is that it increases plasma osmolality by driving up the sodium and the chloride concentration, and now it generates an osmotic gradient between the blood and the brain, and the brain decompresses as water is removed from the brain back into the blood, and this at least temporarily stops the neurological danger. Clearly, if she continues to seize, you need to give her another dose of hypertonic saline. In 150 mils of 3% saline, there are 77 millimoles of sodium and 77 millimoles of chloride. There is approximately the same amount of sodium and chloride in 500 mils of isotonic saline, that's 0.9%, or 60 mils of 7.5% saline. So why not just give 500 mils of 0.9% saline? The reason why is that there is 350 mils more water in that, so it'll have less of a therapeutic effect. Why not give 7.5%? I would if I could find it. I have not seen 7.5% saline available clinically for many years. Let me illustrate this. We're starting with a plasma sodium of 120 millimoles per litre. There are 15 litres of extracellular fluid, so that works out at 1,800 millimoles of sodium in the extracellular space. If you calculate out the extracellular osmolality, then there is 15 litres of extracellular fluid with 248 milliosmoles per litre, or 3,720 milliosmoles in total. If we come along and give 150 mils of hypertonic saline, that contains 144 milliosmoles in total, 77 of sodium, 77 of potassium. The impact that this will have is to drive up the plasma sodium by 5 millimoles per litre. This is very, very, very safe. The impact on the osmolality is slightly less. The total impact on osmolality, remember you're giving sodium and chloride, is about 8 milliosmoles. So as a rule of thumb, 150 mils of 3% saline will drive up the sodium by 5 millimoles per litre and the osmolality by about 8 millimoles per litre. Remember Matthew, the guy I told you not to give hypertonic saline to? He's a patient who came in with a Glasgow coma score of 15, mild flu-like symptoms with a sodium of 120, and I said just leave him alone. And the reason for this is that Matthew is very, very different from Rachel, for example. Now Matthew may well have a blood osmolality of 250 milliosmoles per kilo with a plasma sodium of 120 millimoles per litre. But the key thing is, because he's probably had this for a very long time, probably induced by drugs that he's taking for his congestive heart failure and hypertension, and as a consequence of that, his brain osmolality is likely exactly the same. So his brain osmolality equals his plasma osmolality. Everything has equalized out. And as a consequence, on a daily basis, including today, he's not in any great danger. But the situation is marginal because ingestion, particularly intravenously, of a large sodium load to Matthew, including putting him on an infusion of isotonic saline solution, may actually cause rapid shrinkage of his brain, damage to neurons, and damage to blood vessels. So you need to be careful. Now let's move on to talk about how to work the problem of the hyponatremic patient, because so far I've discussed the osmotic problems and I've told you that you should give hypertonic saline as soon as the symptomatic patient rolls in the door, but we need to figure out what's going on underneath all of this. You need to send 4 tests. The first one is a blood glucose. The second is a serum osmolality. You will need to insert a catheter into Maureen and check her urinary osmolality and her urinary sodium. 4 tests, all essential once you have your blood chemistry panel. The single most important immediate test is to measure blood glucose. And the reason for this is because hyperglycemia is a really common cause of hyponatremia, and you need to confirm or disconfirm that this is a diabetic emergency immediately, because this is eminently treatable but could be fatal. And of course, remember that glucose is part of the osmolarity calculation. Glucose is easy to measure. Hyperglycemia is a common cause of hyponatremia and it's easy to treat. If Maureen has a blood glucose of 40 millimoles per litre, then you can be confident that you have established the cause, for example, HONC or DKA. Once eliminated as a cause, then you can proceed to looking for another. What else do you look for? The tests that you need to do are the urinary and serum osmolality and urinary sodium. If you can measure the urinary potassium as well, that's really helpful. But remember that these results will not arrive for hours. So you must be cognizant of the fact that for the time from when you send those tests to those test results arrive, you are working in the dark and you're treating a patient with inadequate information. But at the end of the day, the treatment is to either do something or do nothing. And the decision to do something, i.e. give hypertonic saline, is based on whether the patient has symptoms or not. I want to rapidly run through the physiology of sodium and water homeostasis. In the middle, we have our plasma sodium and serum osmolality. The sodium level is usually in and around 140 millimoles or 150 milliosmoles per litre, and the osmolality is in and around 300 milliosmoles per kilogram. The body must keep these quantities relatively stable. In the setting of salt and water being ingested by the body at variable rates and times, the body is eliminating surpluses of these materials. This process is controlled centrally by the brain's osmoreceptors in the medulla and the pituitary ADH secretion, and peripherally by the renin-angiotensin-aldosterone system in the kidney. In the setting of dehydration, that is, inadequate water intake or excess water loss, the plasma sodium and serum osmolality increase. The brain secretes antidiuretic hormone, and this causes water retention in the distal tubule and in the collecting ducts and results in a reduction in the urinary output. That urine is highly concentrated, so the urinary osmolality must be high. How high? More than 100 milliosmoles per kilogram. In the setting of overhydration, for example, when one drinks a lot of fluid like water, tea or beer, then the plasma sodium and serum osmolality fall, antidiuretic hormone release is suppressed, and less water is reabsorbed by the kidney. Consequently, the urine is dilute looking and the osmolality of that urine is low. How low? Less than 100 milliosmoles per kilogram. In terms of control of sodium and fluid volume, you need to look microscopically at the kidney. The macula densa is a collection of cells at the junction of the thick ascending limb and the distal convoluted tubule, and it lies adjacent to its own glomerulus. The macula densa detects the amount of sodium and chloride in the distal convoluted tubule and adjusts the flow in the glomerulus via the afferent arteriole dynamically. If the sodium content is low, If the sodium and chloride content is low, the macula densa essentially increases glomerular filtration by causing vasodilatation of the afferent arteriole. If the sodium and chloride content is high, the macula densa reduces GF4 by vasoconstricting the afferent arteriole, and this is known as tubuloglomerular feedback. The other process that is involved in renal blood flow and sodium reabsorption is the renin-angiotensin system. Reduced renal perfusion results in the release of renin into the circulation that activates a cascade of hormones, angiotensin 1, 2, and 3. The ultimate outcome is systemic vasoconstriction and the release of aldosterone from the adrenal cortex. Aldosterone promotes sodium and water absorption and potassium elimination. And that's why it's imperative that if the plasma sodium is low, you must measure the urine sodium, because that's what the kidney does? It holds on to sodium for dear life. And if there is a lot of sodium coming out of the urine, there's something wrong with these mechanisms that I've just described. Just to clarify, the normal urinary sodium is in and about 20 millimoles per liter. When one is dehydrated, then the urine is concentrated and the sodium level is less than 20 millimoles per liter. If the sodium level is more than 40 millimoles per liter, there is a major problem with salt retention in the body. I'll get back to that in subsequent tutorials. Let's just move on a little bit though and look at common things. And remember, common things are common. And the most common cause of acute hyponatremia is water overload. Why does that happen? Because people drink a lot of water. If the patient is water overloaded, then the urinary osmolality should be very, very low. And the lower it is, the more water overloaded the patient is. So urinary osmolality of less than 100 milliosmoles per liter going downwards. So let's look at an algorithm. You have a low sodium. The question you ask is antidiuretic hormone active? If the patient is water overloaded, then antidiuretic hormone should be switched off. In that case, the urinary osmolality should be less than 100. The urine is dilute and the patient is water overloaded. If the urinary osmolality is more than 100, there is a lot of antidiuretic hormone present and the urine is concentrated. In other words, something else is going on. And the reason for this is that sodium dilution can be caused by two things: too much water or other osmoles. If the serum osmolality is low, which it nearly is in all the cases that you see, then there is water excess and hypotonic hyponatremia. This is the majority of cases that you will ever see, but you need to be so careful because if the osmolality is normal or high, then there is isotonic or hypertonic hyponatremia, and the cause of this problem is nearly always toxic. The treatment is completely different and you need to get onto it as soon as possible. If indeed the patient's osmolality is normal or high, you should calculate out the osmol gap and look for a cause. And when you treat that cause, for example, ethylene glycol poisoning, you really want to see that gap narrowing over time. And just to run through a decision tree for this, once you've checked the serum osmolality, if that osmolality is less than 270 milliosmoles per kilogram, you have hypotonic hyponatremia. If it's more than 290 milliosmoles per kilogram with a low sodium, this is iso or hypertonic hyponatremia, and you need to calculate out the osmol gap. The most common cause of iso or hypertonic hyponatremia is hyperglycemia or uremia, but they are calculated so there is no gap. Older lab equipment undervalues sodium when serum proteins or lipids are high. This is known as pseudo-hyponatremia. The blood gas machine does not do so. The blood gas machine gives you a very accurate measurement of sodium. Unmeasured osmoles are rarely byproducts of metabolism. They are either ingested, such as various different alcohols, such as methanol, isopropyl alcohol, ethanol or ethylene glycol, or they have been administered by a doctor or a nurse in the case of mannitol. It's imperative that if you have a big osmol gap, you send a toxicology screen. Let's move on to hypotonic hyponatremia. This is the version that you are most likely to encounter. The plasma sodium is low, the serum osmolality is low, so the extracellular fluid is dilute. The body is trying hard to hold on to solute, so the urinary osmolality should be very, very high. But of course, something is very wrong to upset homeostasis. To me, there are only three options: too much water intake, sodium loss in excess of water loss, or inappropriate water retention. To figure this out, we need to have a look at the patient's labs. The most important aspect to look at is the organ system that controls salt and water output, the kidneys. Are the kidneys working? We need to look at the urea and the creatinine, but it's also imperative that you look at the urinary sodium. A high urinary sodium with a low plasma sodium means that the kidneys are not working. The kidneys are off. Here's a way to work the problem. If the urinary osmolality is high, that means that there are a lot of particles in the urine. We're going to use an arbitrary number of 100 milliosmoles, as I've already mentioned. Then you need to see what is actually in the urine. Remember, if the plasma sodium is low, the urinary sodium should also be low. And if it's more than 30 millimoles per liter, then there is a sodium wasting problem. If the urea is high, then one of two problems is present. Excessive diuresis, principally with thiazides, in which case the urea is typically high with a relatively normal creatinine, or there is a disease process going on with the kidney, acute kidney injury. In that case, the creatinine is elevated. If the urea and the creatinine are normal, then the patient likely has syndrome of inappropriate antidiuresis, about which more later. But what if the kidneys are working? In this situation, we have a high urinary osmolality. We have a low urinary sodium of less than 30 millimoles per liter. What then? The kidneys are clearly working. So this is very, very difficult. If the patient is edematous, then this is an other organ system problem. Either the liver, cirrhosis, in which case the albumin will be low, or congestive heart failure, where the ejection fraction will be low. If the urea is high and the urinary sodium is low, then the patient is struggling to maintain circulating volume, and this is hypovolemic hyponatremia, caused by vomiting, diarrhea, sweating, stomal losses, etc. Again, if the urea is normal, regardless of the urinary sodium, consider inappropriate antidiuresis. So let's look at iso and hypotonic hyponatremia in a single algorithm. We'll start with a sodium of less than 130 millimoles per liter. And the first thing I told you to do was check the blood glucose to outrule a diabetic emergency. If the serum osmolality is more than 290 milliosmoles per liter, this is isotonic hyponatremia. And if the glucose is high, then this is hyperosmolar hyperglycemic syndrome. If the glucose is not high, check for an osmol gap and look for some form of alcohol poisoning. If the serum osmolality is less than 270 milliosmoles per liter, then this is hypotonic hyponatremia. This is 90% of cases. And then we need to look at the urinary osmolality. And if it's less than 100 milliosmoles per liter, this is water overload. If it's greater than 100 milliosmoles per liter, then we need to look at the urinary sodium. If it's less than 30 millimoles per liter and the urea is greater than 10 millimoles per liter, then this is hypotonic hypovolemic hyponatremia. If the urinary sodium is more than 30 millimoles per liter, then we need to look at the urea. We ask ourselves, is the urea greater than 10 millimoles per liter? If it's not, then we likely have the syndrome of antidiuresis. If it is greater than 10 millimoles per liter, we need to look at the creatinine. If the creatinine is raised, for example, more than 150 millimoles per liter, then it's likely that the patient has acute kidney injury. If the urea is high but the creatinine is relatively normal, then it's likely that the problem is diuretics. Now, let's review this tutorial. In this tutorial, I discussed hyponatremia and how it presents. I also discussed the different types of hyponatremia: hypotonic, isotonic, and hypertonic. I then moved on to a discussion about the diagnostic pathway for investigating hyponatremia. Next time, I will discuss common clinical scenarios of hyponatremia. working the hyponatremic problem from these scenarios and the treatment for acute hyponatremia. I'm going to leave you now with the algorithm that I showed you earlier on, and you can pause this video to observe the decision tree that you should take while assessing the patient with hyponatremia. So that's the end of our first tutorial on hyponatremia. Next time we'll go through a series of patients who have hyponatremia and we'll work those problems and talk a bit about treatment. If you're enjoying these tutorials, don't forget to subscribe on YouTube and follow me at ccmtutorials.org.